Gel-based autologous chondrocyte implantation, which is a type of matrix-assisted autologous chondrocyte implantation. What are the evolving techniques and the clinical outcomes? Dr. Rajat. Dr. Rajat is the president of the Indian Cartilage Society and a well-known cartilage reconstruction and arthroscopy surgeon from India. Over to Dr. Rajat.
Thank you, Sashi, for that introduction. So, my screen is visible to you.
Yes, clear.
So, today we are going to discuss about the gel-based autologous chondrocyte implantation, the evolving techniques and clinical outcomes. So, in India, when we started with the ACI, it was the first generation ACI having the periosteal patch and the chondrocyte. So, and in between it was amended for a few years, and since 2014 or 15, we have started it again, and it's a gel-based ACI which is available in India, and we are doing this since last 10 years or so. So the journey of the cartilage repair started with this famous saying by John Hunter that the cartilage injury is troublesome thing, and once injured, it seldom repairs itself. And since then, we are chasing this holy grail, and we are in search of the ideal cartilage procedure since long. And there's more than right answer for the same thing. There are multiple procedures that have been described in literature, from debridement to the microfracture, OCT, and ACI. So the debridement and microfracture, these two things leads to the fibrous kind of repair, and the results are very short lasting. It can be done in a low physical demand patient with a smaller size of the lesion. The OCT and the ACI, they leads to a hyaline cartilage of repair, and it can be done in a high physical demand patient and also for a large size lesions, and the results are also durable. The ACI first done by Professor Mats Bidberg in 1994, and since then the ACI has evolved over a period of time. The first generation ACI had a periosteal patch. Under that periosteal patch, we need to insert the chondrocyte culture. And the second generation of the ACI that had the collagen patch. So under that patch, the chondrocyte, they survived and they grow. And the problem with the first and second generation ACI is the suturing of that collagen and the periosteal patch that makes the surgery longer, and also it makes the procedure morbid. And another problem is the monolayer distribution of the chondrocytes. So what happens with the monolayer distribution of the chondrocyte? The chondrocyte growth is slow, and also the de-differentiation into the chondrocyte is difficult, and more so the collagen that shift from type 2 collagen to the type 1. So we are aiming towards the type 2 collagen repair. So that happens with the monolayer distribution of the chondrocyte. But in the third generation and the fourth generation ACI, they use the collagen matrix, or the fourth generation uses the scaffold, the third generation using a fibrin glue fixation. So these two type of third and fourth generation ACI, they are using a scaffold that leads to a 3D distribution of chondrocyte. So what happens with 3D distribution of the chondrocyte is that it leads to a more viability and equal distribution of the cells, and it leads to a faster growth, also a three-dimensional structure of the chondrocyte in that scaffold. There are different hydrogels matrix that are available. One which we are using in India is the fibrin gel. It is biocompatible and it forms a three-dimensional structures. Another one is the hyaluronic acid that supports the chondrogenesis. It leads to cartilage formation. There are different gels that are available that forms a 3D scaffold, and it promotes the cartilage, and the chondrocyte which we have cultured from the laboratory, it can survive in a three-dimensional structure, and it leads to more so a hyaline like cartilage repair. So what is the rationale for a gel-based ACI? It is injectable and it ensures the even cell distribution. It also avoids the mechanical trauma in terms like a periosteal, sleeves suturing. It reduces the surgical time, it reduces the delamination risk, and it leads to a enhanced integration and also improved biological signals to the chondrocyte and improved cartilage healing. What are the indications for the ACI? Symptomatic. The patient has to be symptomatic, and only asymptomatic patient, and in expectations of the disease progression, it is not recommended to do an ACI. Focal condyle lesion, we can do an ACI. The full thickness defects, 3 or 4 ICRS grade. Typically, the large size lesions more than 2 to 2.5 centimeters square. Even the people have used more than 10 centimeters square size lesion as well. Typically the young patients and high active patient, those are the candidate for the ACI. Before going for any cartilage surgery, you need to treat the alignment first. If there is a malalignment, you need to treat it with osteotomy or some procedure. If there is a meniscus deficiency or a meniscus tear, you need to repair it. If there is an associated instability, you need to repair it. And there are definitely certain contraindication to the ACI as well. Advanced osteoarthritis. So if there is a grade 4 kissing type of bone on bone disease, then you need not to do an ACI. You can just do an alignment correction in this patient or a TKR. That is enough. And if there is a chronic infection or the patient is on immunosuppression or rheumatoid inflammatory arthritis, in those cases, ACI is contraindicated. And with my own experience, I've learned that the OCN, the osteochondral necrosis patients, if those lesions are progressive, that means you have seen the patient and it is likely to progress in near future. So try to get the patient when the patient is having the maximum disease progressed. So that means that there is some hold to the disease and it is not progressing for some period of time. Follow the patient for a few years. Then you can go for subchondral bone grafting and the ACI, that is the overlay ACI. But if you do ACI in those patients where the disease is progressive, then you will treat the patient partially only, and the patient will come to you again after a few years with a failure. So try to do in the patient where the disease has halted for few more years. And those patients, those are not compliant to the rehabilitation, those are smokers and obesity. So these patients are likely to heal, not to heal well in this patient. So I will try to demonstrate a case here. This is a 23-year male patient, anterior knee pain since 2 years, and the pain is more during the activity of playing. And this is increased with the prolonged sitting and also stair climbing. There is no history of trauma. The patient is a professional boxer and he has the patellofemoral crepitus. Other than that, there is no instability. Other clinical examination of the knee is normal. So this is the MRI of the patient. We can see a full thickness condyle lesion at the patellar apex. So if we see this patellar apex, this is the most thickest cartilage in the body. The cartilage here is approximately 7 to 8 millimeter thick. So if we compare it with the femoral condyles here, the cartilage is 4 to 5 millimeter, and on the periphery it is 3 to 4 millimeter. So there are very high amount of stresses here, and also we can see a subchondral small cyst here as well. So this cartilage is quite different. So treatment of the cartilage lesion on the facets here and the treatment of the patellar apex is quite different since the forces are quite more. So in this patient, also it is very difficult to match the contours if we try to replace this with the osteochondral cylinder transfer from the lateral femoral condyle non-weight bearing portion. So OCT plugs is hardly having a 3 to 4 millimeter of the cartilage. Here the cartilage thickness is more than 8 millimeter. So it is very difficult to match the cartilage thickness as well, and also difficult to manage the contours at the apex as well. So this is possible with the ACI. So we have done the ACI in this patient. We have counseled the patient that you are going to require a 2-stage surgery for this, since this is a lesion at the patellar apex. So first stage is the biopsy that we need to take from the same site. We harvest the osteochondral cylinder transfer, that is a lateral femoral condyle, or we can take it also from the medial femoral condyle anterior non-weight bearing portion. And it is essentially an arthroscopic biopsy. We use the same harvester what we use for the osteochondral cylinder transfer. And previously we used to send a 8 millimeter plug, and this should have at least 10 to 12 millimeter of the subchondral bone with itself. And this cartilage is grown in the laboratory for 3 to 4 weeks. And after that, they will confirm the cell viability, cell count, phenotypes, whether it's a cartilage that has grown. Sometimes it's not possible to grow the cartilage despite the fact that you have sent the sample. So they check it for the cell viability and whether it is a cartilage or not. So in this patient, after 4 weeks, we did the biopsy in January 2017, and we received the cell in February after 4 weeks. And these are the adult live cultured chondrocyte. They come in this vial. They are transported with a cold chain maintenance to us. And in every every ml, we have a 10 million cell. That is 10 million cell every ml of this cultured chondrocyte gel, and it can be up to 60 million. And the 1 ml fills the defect in the 1 centimeter square size. So if you need a more chondrocyte for a larger defect, then you need to tell your supplier that I have a lesion size that is approximately this much size, and I need some additional cells. So in that case, they can supply you some additional vial as well. So these are two syringes. One syringe is filled with the fibrin, another syringe is with the chondrocytes. And these are the different instruments that are available with me during my surgery. So we have these different sets of sets for the debridement and also the other procedure that require for the cartilage ACI implantation. The second surgery, the second step of the surgery was done in February 17, and the surgery can be done arthroscopic or open. But since patella, you need to invert the patella, so it is essential that you need to do an arthrotomy. It is essentially a medial arthrotomy for patella, and you invert the patella so that this gel is, by the effect of gravity, is not spilled in the joint. And you can do it arthroscopically also for the femur, but for patella it is essential to invert the patella and do a mini arthrotomy. So first thing is to assess the size of the lesion primarily. This is not the definitive size of the lesion. This is just at the initial point, and this appears to be approximately 8 into 8 millimeter size. So the final size is going to be after the debridement only. So since it was a small size, 8 into 8 millimeters, so I've used the OCT plug harvester to debride the defect. So it gives me a smooth rounded contour to me so that I can implant the ACI well. So it was a 8 millimeter size cylinder, but you also need to check the integrity of the surrounding cartilage, whether this cartilage is also soft. So even if after your full debridement, the surrounding cartilage is soft, you can do more debridement. Like in this case, when I did check the surrounding cartilage, this was also soft. So I checked the surrounding cartilage. So it was soft also. So then I further extended my debridement. So after that full debridement, the defect size was approximately 1.8 into 1.2 millimeter size. So this was near the apex after full debridement. Since this was not involving the subchondral bone more than 4 millimeter, so I didn't do any bone grafting to this. Since it is mentioned in the literature that if the the subchondral bone involvement is less than 4 millimeter, you can just do the ACI implantation. So this is the syringe which is supplied with the chondrocyte culture. So in the one syringe, there is a fibrin glue, and in another syringe, there is the chondrocyte culture. So you need to pour the ACI culture drop by drop. So the fibrin glue settles the chondrocyte. So this is settling in. You need to be very slow and wait for the drop to settle down. And this is after the final implantation. So we can see that there is a smooth contour of the cartilage that is covered. So this is not possible with the OCT, and this is possible with the ACI only. And after you have fixed your ACI, you need to pass the knee through the gentle range of motion, and you need to check for the stability. So you just need to do 3 or 4 knee bending and gently pass it through the range of motion. So if everything is stable, then you can proceed with the closure. And we can see this is very much stable, and we have done the post-operative MRI at 1 year. On this MRI, we can see the thick cartilage that is grown over the ACI implantation, and subchondral bone is also covered. There are some artifacts inside this grown cartilage, but we can make out that with the manufacturer that there are certain cartilage things that are there in the MRI, but this eventually stops with the maturation of the graft in subsequent years. And if you will follow the patient for a few more years and do an MRI again, then this is going to be very, very thick matured cartilage in the following years. And we have done this case in 2017, and after we have done the follow-up since last 7 years, but this is the last follow-up. This is a boxer, and he's doing all the sporting activity since last 5 years. So this is a very successful outcome of this patient, and our own experience about the ACI is a small case series of 7 cases, 7 cases in femur, 3 cases in patella. We have evaluated our patient with the Lisson and Kuzala scores, and the minimum follow-up is 1 year and the maximum follow-up is 7 years. And the outcome with these scores have been good to excellent.